something that I see a lot, but I've actually not presented on it before. So in the feeding disorders clinic at Kennedy, we see kids with a wide variety of developmental disabilities, birth defects, other gastrointestinal problems, children who mostly have feeding problems, but often GI problems as well. And I would say right now, about 40 to 50% of the children have autism spectrum disorder as one of their diagnoses. And so a lot of the children that we're treating have ASD, but it's not really that we're only focusing on children with ASD. And so, I've done a fair amount of reading and thinking about GI problems, and there's actually a lot that's been written and some research that's been done on GI problems in children with autism spectrum disorders. So just before I get going, really, I know there's some staff in the audience. Who's Kennedy staff? Okay, a lot of you. Who's staff from elsewhere or professional people from elsewhere? And some of you probably wear more than one hat. Some of you are maybe parents of children with autism spectrum disorders. Okay. And does anybody have any specific topics they're really eager to talk about or hear about today? Just so I have it in mind as we go. It'll be a little loose. Okay, nothing. All right, so I don't have any conflicts of interest and nothing important to disclose. I'm not going to talk about anything that I have a financial interest in. I don't own stock in Miralax, although I'm going to mention it. So I want to talk about common GI concerns in children with autism spectrum disorders, to discuss management of common GI problems a little bit and as much as you're interested in hearing about it, and to briefly discuss some of the theories about the relationship of autism to GI problems. And I'm certainly no real expert on that, but I think it's a pretty interesting area and one that's they're hoping to do more research on. So this is how I kind of framed my thinking about the whole topic. Okay, so when I started reading about it and learning more about it, there's certain papers, research that specifically addresses what are the GI problems that children with autism have. Okay, and then there's a lot related to feeding problems, which aren't exactly the same. Kids who are selective and refuse and have strong food preferences and may end up with nutritional problems because of what they're eating, or nutritional problems related to GI problems. So there's a literature on what are the nutritional problems and deficiencies of children with ASD. And then there's a whole series of papers related to potential underlying mechanisms or underlying problems that relate GI problems to the cause of a developmental disability. Meaning, if you have something wrong with your gut, that maybe that actually causes a developmental problem. Okay? And they're all really theories. There's nothing that's been proven as of yet. And then there's a whole group of papers on dietary interventions for ASD. Probably the most common that you've all heard of is casein-free, gluten-free diets, but all sorts of other dietary interventions that have been tried and discussed, and none that have actually been proven to work. But that doesn't mean that they wouldn't work. It just means they haven't been proven to work. Anyway, so one way that we think about GI problems in ASD, one of the things that's been the most studied is actually what's the prevalence. Does everybody know what prevalence is? It's how common is something in a population. So we could talk about how common are GI problems in all children. Well, they're very common in all children. Probably 30% or so of all children have a GI problem at some point during childhood. Okay? And what are the biggies? Anybody, can you think of what are the big GI problems? Diarrhea, right. Constipation, reflux, vomiting, abdominal pain. They're the exact same problems that you see in children with autism spectrum disorders. So we're not seeing different problems, but there actually has been a suggestion since some papers came out in the late 90s and built on since then. And actually, I was just looking a couple days ago and I found a paper. I don't have my pointer, but this paper is actually hasn't even been fully published yet. It just came out in May 2014. so today's April, right? So it's coming out in this issue of Pediatrics this month. It's a meta-analysis of all the past studies related to GI problems in ASD, and basically they concluded that GI problems are reported 4 times as commonly in children with ASD than in typically developing children. So reviewing all the past evidence. And so there's really been a range in the literature, everything from it's no higher in children with ASD than in typical children to it's much higher. And it all depends on the methodology of the study and the population that they looked at and the type of tool that they used to evaluate GI problems. But basically this paper is a meta-analysis. It's in a pretty significant journal, and it's saying, yes, we believe that kids with ASD really do have more GI problems than other children. It doesn't say why, though. So the other big question is, why do they have more GI problems than other kids? And the most common problems, again, abdominal pain, diarrhea, constipation, reflux, vomiting. But those 3 are the biggies: abdominal pain, diarrhea, and constipation. And then another paper a few months ago in another journal, I thought it was a pretty good study. They studied, I can't remember the exact number of children, but they basically found that of children with autism spectrum disorders, about 49% reported 1 or more GI complaints lasting 6 or more months. So chronic problems. And the biggest was constipation again, diarrhea, bloating, gas, flatulence, that kind of thing, vomiting, reflux. Same problems we see in other kids, just in higher percentage. I put here prevalence has not been established completely because there's still these differences in methodologies, and what we don't know is even in typical children what's the true prevalence, because nobody's really studied that even all that well. So we can't say for absolute certainty, but we have a very good idea that it's higher than normal. And the other issue that a lot of people bring up is, how do we determine when somebody has a GI problem? If you come and see me as a doctor, as a physician, how do I know that you have a GI problem? I ask you, I say, do you have any abdominal pain? Does your belly hurt? Do you feel nauseous? Are you losing your appetite? Have you lost any weight? You ask a lot of questions. And in kids with autism spectrum disorders, you all know, they have difficulty in some cases with communication and answering questions. So how do we measure these symptoms? And are we underreporting or overreporting in some cases? Are we misinterpreting symptoms in some cases? And a big thing that people say we need more of is tools for evaluating GI symptoms, specifically in children with autism spectrum disorders, and we don't have one right now. We don't have a tool that has been made specifically for kids with ASD for evaluating their GI symptoms. So to really know the true prevalence and to be comfortable with that, we need a better tool that's validated and reliable and all that kind of stuff. So again, same ones, most common GI problems. And then I put, these are all functional disorders. So these, they're symptoms. They're not, I haven't told you why does the kid have diarrhea, or why does the kid have constipation, why they have excessive gas, or why they have vomiting reflux. And a lot of times those things we consider functional, meaning your GI system, if we evaluate it medically, if we do endoscopies and colonoscopies and blood work and stool samples and all that stuff, we don't find anything wrong, okay? Not that sometimes there are things you find wrong that cause all these things, but a lot of times, especially in kids with neurodevelopmental disabilities, we do big workups and we don't find anything wrong, and we say it's a functional disorder. So what are the functional disorders that people think about in adults? So the most sort of talked about common one is irritable bowel syndrome, right? So irritable, not inflammatory bowel disease, I get them confused sometimes. Irritable bowel syndrome, IBS, means people who have problems with bloating, gas, constipation, diarrhea, and sort of a very sensitive GI tract. But when you study them, nothing wrong, right? Doesn't mean you can't treat the symptoms. People put them on meds, they change their diet, they do all sorts of stuff, but they don't find anything wrong when they do testing. And we think it's functional, but it's also, we think it may be neurologic, Okay, so functional disorders in some cases are due to an abnormal nervous system, and we know kids with ASD in some cases have an abnormal nervous system. So people are thinking maybe some of the functional disorders in kids with ASD are because of abnormal nervous system regulation of the GI tract, or sometimes people call it neuroenteric. So like neurology, enteric, E-N-T-E-R-I-C, like enterology, or it means intestine, neuroenteric dysregulation. And then I put down here selective eating. So selective eating is just one way of saying kids who have strong food preferences, who have food refusal, who have aversions, who may eat a narrow range of foods or a limited diet. So all of these symptoms, and this is how we think in feeding disorders clinic, we get a kid who comes to us because usually the parent is saying, my child only eats five foods and I want to expand their diet, or they have a lot of mealtime behaviors that are a problem, and they get to this. Well, what about all these things that are contributing to this? So if a kid has abdominal pain and bloating every time they eat broccoli, then they're not going to eat broccoli, right? That's just an example, but there's probably lots of other reasons why kids learn not to eat foods. So they're learned behaviors often because of symptoms. Sometimes we can figure out those symptoms, and sometimes we can't, because oftentimes the kids can't tell us. But most of the time the testing doesn't really tell us a whole lot. So anyway, this is my long list. This is a busy slide, but it's basically my thinking about what are the different reasons why kids specifically with autism spectrum disorders might have more GI problems than other kids. Okay? So I tried to think of categorically what are all the things I can think of. So a lot of them have an abnormal diet, and that abnormal diet might contribute to the problem. That is, a kid who doesn't eat any fiber, doesn't eat fruits and vegetables, might have a lot more constipation than other kids. So is it something about autism that makes them become food selective that changes their diet from a more balanced, normal diet that then leads to all these other functional disorders? And it may be all of that. Okay? Or maybe that's just part of it, and then there's other things going on. A lot of them we say have oral aversion. They're sensitive to certain kinds of textures. Some of them can't stand slimy textures, and some of them can't stand crunchy textures, and some of them can't stand, sour and bitter, and some of them crave sweet and salty. But whatever those sensory responses are, it may lead to altered food preferences and then lead to GI problems. Also, some kids are very sensitive in a physical way. You put certain foods in their mouth and they vomit. Okay, so some vomiting and gagging is actually a response more to oral stimulation and taste and texture than it is a GI problem going on in their lower GI tract. So there's a lot of kids that we see who vomit, and we sort of treat it as behavioral vomiting, but it's really that they're very sensitive in the oral area. And we do actually, in our program, we have ways of trying to extinguish that kind of behavior by re-exposing them over and over again to the same thing, and then gradually it diminishes. Anyway, other behavioral factors. So if you take a typical child, right, who is constipated, and you can explain to them that they're constipated, and you can tell them, okay, you have to sit on the toilet and you have to push and have a bowel movement, they may be able to do it. It's a lot harder in a kid with an ASD to say, okay, sit on the toilet and push and have a bowel movement, especially if their previous bowel movement was large and painful, and they pass it, and then they're like, I'm not doing that again. And so they may be avoidant, and so that may lead to more problems. So it may be worse behavioral issues that are contributing to especially things like constipation. And I sort of, whenever I talk to parents about constipation, I sort of just, one of the things I tell them is, look, if you're constipated, if your bowel is loaded with stool, okay, and that's the exit from the GI tract, right? Anything you eat above that, it's like putting water in a stopped up sink. It's going to all back up, right? So kids who are constipated get more bloating, get more gas, get more reflux, get more vomiting. So sometimes that's the primary problem, and it just backs up the whole system. So if we're very aggressive in treating constipation, which sometimes improves a lot of the other GI symptoms. And I think the constipation is the most behavioral related GI aspect. Medication. So a lot of kids with ASD are on medications that cause GI symptoms. So like if you think about, okay, lots of kids on Ritalin and stimulants, what do? They decrease your appetite. They may make you more likely to vomit and gag. They may worsen reflux. They may cause abdominal pain. They may cause headache. They may cause nausea. They're stimulants. So when you stimulate the nervous system, it shuts down the GI tract. So you rev up the autonomic nervous system, the sympathetic system, and it slows down your GI tract. And so there could be a lot of symptoms related to those meds. Antipsychotics. They often have anticholinergic side effects which slow down the GI tract, cause constipation in some cases, some cases diarrhea. People use SSRIs, which are like Celexa and Lexapro and Prozac, and there's about 10 of them. They can cause constipation in some cases. They can cause diarrhea in some cases. They can cause loss of appetite. They can cause, you never know what an SSRI is going to do. It can do both, and depending on the child. And I think a lot of times, and I'm going to pick on psychiatrists a lot, we have a lot of psychiatrists who work here. I like them all. I think sometimes they're working in isolation. You know, they're the mental health provider. They know about these drugs and how to use them behaviorally, but sometimes they don't think about all the side effects they're causing with all the drugs they're using. And are they asking questions? Are you pooping okay when you come to see me? Are you eating okay? Are you, I'm sure they're asking some of these questions, but a lot of times I'll find patients on a mix, a cocktail of medications, and then the parents are wondering why the kid's lost 30 pounds in the last 6 months. And I say, what meds did you start 6 months ago? And they say, oh, I started that stimulant. And, oh, okay, maybe that was why you lost weight or why things changed. So I think we always have to look back at medications. And it's not just meds. Any treatment you do for anything has the potential for side effects. So you always have to monitor for treatment effect, and you have to monitor for side effect. And it can and GI side effects are very common with any sort of treatment, whether it's diet, supplements, whatever. So other underlying conditions that are seen in the general population that can cause GI symptoms in kids with ASD. So right now in the United States, we think that about 1 in 100 people have celiac disease, right? So that means 1 in 100 kids with autism spectrum disorders ought to have celiac disease. So they're just as capable of getting these diseases as anyone else is. Food allergies. 5 to 10% of children now in the United States we think have food allergies. Well, 5 to 10% of kids with ASD probably have food allergies. How kids respond with ASD when they have these things may be different. So a more typical kid with a food allergy may respond, I don't want to use the word normal, yeah. So a more typical kid who has a food allergy might respond in a way where they say, okay, I'm not going to eat peanut, and they avoid it, but they don't necessarily generalize it to other foods or may not overreact in some way. Whereas a kid who has food allergies and also has an autism spectrum disorder, they may vomit with certain kinds of foods, and it may be, say, a green food, and then they generalize it to all green foods or things like that. I'm making up something. But we see a lot of kids who've had adverse reactions to foods where it becomes much more generalized and they develop a lot more anxiety. And so I think a lot of that goes along with autism spectrum disorders. And my belief is that a lot of the problems are the same problems we see in any other kid, but the reaction to that problem is very different. And that we need to be sensitive to that. We need to be better at screening for problems in kids with ASD, and we need to be more sensitive to how to treat those problems given the developmental problems, communication problems, I mean, for example, I've had a number of adolescents with autism spectrum disorders who were constipated. right? In a more typical adolescent who's really backed up, I might say, well, drink this gallon of Go Lightly at home and then give yourself an enema and sit on the toilet for the next 2 days and you'll be better. Well, you can't do that very easily. So a lot of parents of kids with autism spectrum disorders will say, I cannot go near their rectum with an enema or a suppository. That's out of the question, off the table. So we have to find other ways of treating those problems. Neuroenteric dysregulation, I mentioned that already. The idea that even if you have a developmental disability in general, and we see this a lot with cerebral palsy and other disorders that, where there's a lot of motor problems as well. Kids who are hypotonic, kids who are spastic, they often have constipation, reflux. But it's less well appreciated that maybe some of those same mechanisms are also contributing to GI problems in kids with autism spectrum disorders as well. Genetic factors. So, and I don't know the details of this. There's been at least one study that looked at, or actually several that looked at something called MET. Does that ring bells with you guys at all? I guess it's a protein that is a candidate for being abnormally regulated in some kids with genetic autism. And it also, if it's abnormal, causes GI problems. So there may be, so that's one example of a specific gene abnormality where it may set you up for both autism spectrum type problems as well as GI problems. I'm not saying that that's common, but it's certainly possible that it happens in those cases. Mitochondrial dysfunction. You guys probably have heard that there's a high suspicion now of mitochondrial problems in kids with autism spectrum disorders as an underlying cause. Is that something that rings a bell? Okay. So it is something we think about at Kennedy Krieger a lot. I don't know if, across the country everybody's thinking about it. I've seen articles that certainly refer to it. And kids with mitochondrial disorders have a lot of GI problems. So that may be a subset of kids with autism spectrum disorders where the mitochondrial disorder is the underlying problem and it causes both ASD and it also causes a lot of GI problems. So they get a lot of problems with impaired gastric emptying, constipation, reflux, all those functional problems that I mentioned. Does everybody know what I mean when I say mitochondrial? So mitochondrial is the organelles in your cells that are responsible for energy metabolism. They basically break down glucose and create energy, and then that energy drives, it's the power source for the cells. And when there's a problem with energy metabolism, then certain cell populations can be more affected than others. And so in some cases it could be your pancreas, in some cases it could be your liver, in some cases it could be muscle, and often it's brain and nervous system that gets affected too. And do I need to say any more about mitochondrial disorders? Any questions related to? Okay.
You said that the Kennedy Krieger really focuses on that.
There's people. Well, so I know Deepa Menon thinks a lot about it, who's one of the neurologists here, and I'm sure Stuart Mostovsky does as well. So the physicians who are doing the diagnostic evaluation of children with autism spectrum disorders, looking for underlying causes. So they'll do sort of a standard battery of kinds of tests. So one of the tests that we usually do is a SNP array now. So SNP array is single nucleotide, and it's replaced the karyotype. And the hit rate is probably somewhere around 15% for an abnormality. So that finds missing pieces of DNA or extra pieces of DNA, and it looks at all 46 chromosomes. Then some people, a lot of people believe that an MRI is important for every kid. And sometimes the MRI may have a suggestion of a metabolic problem based on the pattern of abnormality, although most kids with autism spectrum disorders have a relatively normal MRI, except in a research kind of MRI. And then some, but not all, are doing some limited metabolic screening, and then if they see any abnormalities on the screening, then they pursue it more. So I don't know for sure exactly what they're doing here. I know, but I know so one of our geneticists, who's a metabolic guy, Richard Kelly, have you heard that name? So he doesn't typically see those kids, but he talks to, so he likes to be more in the background and giving other people advice on what they should be testing for. And he has a whole protocol on how to evaluate it. Anyway, so, and then I think one of the most interesting things, but the one that's the least well understood, is there underlying intrinsic abnormalities of the GI tract that you're basically born with or that develop early on in life that lead to the symptoms of autism spectrum disorders? So could GI problems actually be the cause of autism? And I would say probably not in most cases, but there may be something going on there. So people have raised the possibility that there's increased permeability, that is, movement of things across the gut, okay? So that, say I eat something, and it's digested in my GI tract, and some of the larger particles, normally, if they're not fully digested, they'd come out the other end, right? But in some people with autism, maybe, the larger particles, instead of coming out the other end, they actually cross the gut wall and go into my bloodstream and then can have an effect on my brain and other things. So that's actually where the casein gluten opioid hypothesis comes from, that the gut is leaky, that you have casein and gluten, which are proteins that are broken down in the gut, but they're only broken down to peptides, which are smaller pieces of protein. And normally they wouldn't get into the bloodstream, but in people with autism, maybe they do. And then these peptides, even though they're food, they look like opioids, which are drugs like morphine and oxycodone and heroin, and that those drugs then get in the bloodstream and then affect your brain. And so that the opioid effect would be decreased brain activity in some ways. So this hypothesis, I actually have another slide that addresses it, was, I guess, introduced in like 1991, and then it gradually led people to try the casein-free, gluten-free diet. I think then at the same time there was an increased appreciation of gluten-sensitive enteropathy, which is really a disorder, celiac disease, and they got sort of mixed together, and then people started, trying out this diet. Anyway, so that's one idea of increased permeability. There's also a possibility that there's other substances that may go across a leaky gut, and then another idea, there may be inflammation in the gut. So there could be inflammatory states in the gut that then affect your nervous system and your brain, and how could they be related? The gut microbiome is basically the idea that you could have bacteria in your gut. So everybody has bacteria in their colon, right? It's actually more bacteria in your colon than there are cells in your entire body, okay, because they're smaller. Yeah.
Question. Why gluten and casein? What's special to
Well, I think I didn't actually go back and find the paper that talked about it. I more read something else that described, but I think the hypothesis was that those proteins, when they're broken down, look a lot like opiates or opioids, that biochemically they're similar, and so that they might have the same effect as opioids if they actually get in your bloodstream. He probably also was thinking, what are common things in the diet? Well, gluten and caseins from milk, and gluten from wheat and rye and barley, yep, but not oat. So anyway, I don't know anything more than that. So you're pushing the limits on my knowledge there. But anyway, so abnormal flora, we call it flora, or abnormal bacteria in the gut, we know can cause problems, right? So does anybody know of a common disorder that is due to altered bacterial flora in your gut? Crohn's disease is probably related to, and it hasn't really been identified exactly what it is, but definitely people think of that. And then there's an infection that people get after they've been on antibiotics, C. diff. So that's Clostridium difficile infection. C. diff lives in your gut all the time. So it's not like an infection that you didn't have before. But what you do is you take antibiotics, it kills off the good bacteria, and you get a growth of C. diff because it's not susceptible to that antibiotic. Just like people who take antibiotics and get yeast infections, that kills off the good bacteria and then the yeast overpopulate. But the yeast were there all the time. They just had the opportunity to grow. So we know that alterations in your gut microflora can cause disease, right? And another example is, people take probiotics, right? So probiotics are good bacteria that people take in order to improve their health. And there have been some studies showing that probiotics help in decreasing length of diarrhea after infections, and for certain kinds of conditions can be fairly helpful. So we know that bacteria is important. Now, how that relates back exactly to ASD, nobody's certain, but people have tried probiotics for treatment of kids with ASD. I don't know of any examples. I haven't heard of any parents coming in and saying, I gave my kids Culturelle and they started doing a whole lot more than they were doing before. But I do think there is a role for probiotics in treating gastrointestinal problems. And I think that we need to do a lot more in terms of evaluating the relationship of the gut microbiome and ASD. And actually, in the last month or two, which is weird because I agreed to do this talk first, and then I got asked by somebody from the Wendy Clagg Center for Developmental Disabilities to work on a letter of intent to Autism Speaks for a grant that they have, and it's specifically on this topic. And so one of the things we're thinking about is how can we study gut permeability and the gut microbiome in kids with autism spectrum disorders. Anyway, so it's interesting. So if a child has all these symptoms that I've talked about so far, what are things that would make you more concerned and want to do more of a workup, meaning diagnostic evaluation? When would I want to start doing endoscopies and blood tests and stool tests and all that kind of stuff? Well, clearly if there's weight loss, okay, any kid who's losing weight, unless it's intentional because they're overweight, is not a good thing. So we always consider weight loss a big red flag. Growth stunting means they're not growing in height as well as they should be. Okay, so any child whose nutrition is affecting their growth and height. And the way we would track that is, so like I'm short, right? So I'm going to always be short on a growth chart, right? So if you plot me out year after year, I'll always be at like the 5th percentile, right? But if somebody's at the 80th percentile and they fall down to the 50th percentile and then they fall down to the 30th percentile, that means they're growing less quickly as other kids their age, and that would be growth stunting, even if they're still in the normal range. And then a kid who falls off in height even below the normal range, you have to be even more concerned. Blood in the stool. So I'm talking like bright red blood in the stool. Everybody knows stool's a bowel movement. If you have black tarry stool, that can be an indication that there's blood, or a very foul smelling stool could be an indication of the blood. And then some gastroenterologists might say, okay, you're coming to me for GI symptoms like constipation and diarrhea that have been fairly chronic. I'm concerned about the possibility of inflammatory bowel disease or other things. I'm going to give you these Hemocult cards and have you take stool samples, and we'll check for blood on those things. They do this more with adults than with kids. But so there's ways of looking for occult blood, which is blood that's not obvious to the eye. So that would also be a reason for doing more workup. So fever mainly because of infection and inflammatory bowel disease. So if you have chronic unexplained fever or fevers that come and go without any explanation, that could be a sign of an underlying disorder. Persistent vomiting that's unexplained. Just in general, persistence or duration of symptoms and severity. So anybody who's having 5 sort of loose bowel movements a day and it's been going on for several months, I would probably pursue that more than a kid where it's only been going on for a few days. Right? So a few days is probably self-limited, a virus or something been going on for a long time, then you're going to work it up more. Anemia. So if you have blood loss or poor absorption of iron or poor absorption of vitamin B12 or folate or other things, you might develop anemia. So if you have anemia, that may be a reason to pursue, it's a marker of not great nutrition in some cases, or blood loss, and so you might do a workup. Other laboratory markers, so if somebody's coming to you and they have a lot of abdominal pain or diarrhea or even constipation, and then you do some simple blood tests and you see, wow, their SED rate, which is a marker of inflammation, is elevated, then that's going to push you to do more other studies. Family history of inflammatory bowel disease or other abnormal physical exam findings. Like, so if they have a big liver, you're going to pursue that. If they have a big spleen or if they have a big fecal mass, you're going to pursue it. So there's definitely things on exam. But say you see a kid, they're growing okay, there's stools, there's no blood, there's no fever, they're not having vomiting, you know, even with alternating constipation, diarrhea, but nothing else to suggest inflammatory disease and fairly normal physical exam, I'm not going to do a lot of diagnostic testing because in most cases it's going to be functional disorders, and we see this in typical kids and we see this in kids with ASD, and so we don't necessarily want to put all those kids under anesthesia and do a lot of invasive testing and things like that. We might do some screening labs if we're at all uncertain, but the biggest thing is, are they growing okay, and is their weight for height normal or their body mass index normal, with what's called empiric treatment, meaning you just assume that the child has the most common thing and you go ahead and you try and treat it. So I would say, and I put abdominal pain under all three of these things, but if they have abdominal pain or symptoms of reflux, you might try treatment with a proton pump inhibitor. So a proton pump inhibitor, the most commonly used ones in kids are going to be Prevacid and Prilosec. So anything that ends in azole, as the generic name, is going to be a proton pump inhibitor. And usually within 2 to 4 weeks, you're going to see some improvement. So the idea is you put them on the med. If they improve after 4 weeks, then you're pretty sure that the med did what it was supposed to do and it treated the problem, and now we don't need to do an endoscopy to determine what's wrong. If their pain and reflux symptoms go away. Abdominal pain and constipation. Constipation is a major cause of abdominal pain in kids. Do a trial of Miralax. So that tends to be the constipation remedy we use the most now. There's a lot of stuff on the internet about any drug, and there is stuff about Miralax saying it's got the same chemical in it as antifreeze, but it is a chain called polyethylene glycol that's 3,000 long. Ethylene glycol, which is an antifreeze, is just a few carbons long, and they sound the same. Polyethylene glycol can be broken down into antifreeze, but it's not the same, and it's actually goes in one end, it comes out the other. It's not absorbed at all, and there have been lots of studies to show that it's safe. But there's stuff on the internet that tells you it's terrible, and you can look up any drug and find things like that. So I've had to explain to people this a number of times. But anyway, we use it because, one, it's usually easy to sneak into food. It comes as a powder. You can mix it in with drinks and purees and applesauce and all sorts of things. It's very easy to dose because it's a powder, so you can adjust you can give large amounts, small amounts. And given once or twice a day, it generally works, and it doesn't cause a lot of cramping like some other things do. And like I said, if you can't do enemas and suppositories, then it's often a way to go. And I can tell you there's a lot of kids who have loose stools when they're really constipated and they're having leakage of loose stool around a large blockage of stool in the rectum. And so that even kids who have sort of loose stools, or they're having bowel incontinence, which we call encopresis, that can often be to constipation. And so treating constipation aggressively with Miralax actually gets rid of the loose stool, surprisingly, so it's counterintuitive. And then abdominal pain and gas, so another empiric treatment is just many people in the general population are lactose intolerant, right? So that means when you're a baby, what do you eat? What are we supposed to eat as babies? We're supposed to drink breast milk, right? Breast milk has lactose in it, right? So nobody is born incapable of digesting lactose. Every baby can digest lactose except for rare disorder called lactase deficiency, but that's very, very uncommon. As you get older, because normally in caveman days you didn't have access to milk after you weaned from the breast, your ability to digest lactose diminished, because lactose is only found in milk. It's not found in anything else, naturally. But we use dairy in all sorts of things that we make, so now it's found in Western foods a lot, right? So lactose. And so many older children and adults can't tolerate lactose at all. And what happens is it goes through their gut, it's not absorbed, and it gets into their colon where it's fermented by bacteria and creates gas. So they have flatulence, farting, they get cramping, and often loose stools, although occasionally constipation. So the biggies are gas, cramping, loose stools, typically, with lactose intolerance. And even today, I heard from a family, every time I give my kid ice cream, he gets cramps. Well, that's probably lactose intolerance. So what can you do about that? You can give lactose-free diet, or you can give Lactaid, which is, Lactaid is prepared foods that have the lactose digested or have some enzyme added. Or you just make sure that they're only, and it's not like an allergy, it's dose dependent. So the more lactose you have in your diet, the more intolerant you are. Just minimizing intake of lactose is probably good enough. It doesn't have to be lactose free. So those are 3 common causes of GI symptoms that we can treat without doing much of a workup, and if they get better, then you don't really have to do anything further, which is the way oftentimes we like to do things in pediatrics, because we don't like to do lots of workup. So anyway, what are some of the diagnostic considerations? You know, like if they have these other symptoms that I already talked about, what are the things you can do to evaluate GI problems? Well, you can do x-rays. So we frequently do x-rays of the abdomen, a plain x-ray, mainly looking at the stool burden. Are they constipated? Is there a big blob of stool in there that we need to get out? Is there any sign of obstruction? But there's not much else you're going to see on a plain x-ray. Then there's, ooh, I spelled, no, I guess I did okay. Upper GI series is when you drink barium, okay, and you watch it go down, okay, and you look at the anatomy of the esophagus, of the stomach, of the small intestine, and you're seeing how things look. And so it's going to determine, is your anatomy normal? Is there any evidence of obstruction? Is there anything contributing to reflux? Okay, so you're mostly doing the upper GI for vomiting, reflux, abdominal pain symptoms. If it's just diarrhea, an upper GI is not going to tell you why somebody's having diarrhea. Stool studies. So you can look at stool for infectious causes. You can look for evidence of inflammation. You can look for evidence of malabsorption. So malabsorption means you're not absorbing all the nutrients from the food that you should be. And so you can look at fat malabsorption. You can look at protein malabsorption. You can look at carbohydrate malabsorption. And then other tests would be in blood. You can look at a CBC, which is a complete blood count, mainly for anemia, evidence of iron deficiency, your white blood cells. You can look at markers of inflammation. You can look at evidence of nutritional deficiency. So you might see just in standard blood work low protein or albumin, which tells you they're not usually getting enough protein intake, or they're losing protein in their gut. But you might also check other things like vitamin D levels. We check them in almost everybody when we draw blood, and they're almost all low.
Low meaning how low?
Anywhere from 5 to, which is really low, to most are in the 20s.
At 20.
In the 20s. So normal vitamin D range is 32 to 100 picograms per milliliter or something like that. So we almost put everybody on a vitamin D supplement who we actually look for it, and we usually do either 1,000 or 2,000 international units per day, just because you can find those doses easily. And they come in liquids too. If you go to Amazon.com, you can find anything, and it's pretty cheap there too. Also, Walmart has a good site for supplements as well that are relatively inexpensive. I guess so I don't miss it. there have been some studies on the nutritional status of kids with autism spectrum disorders. And for the most part, most kids with autism have normal body mass index early in life and actually later become obese, not underweight. And most don't have any major nutrient deficiencies. They tend to have the same exact problems as other American kids, but sometimes a little bit worse. So they tend to be iron deficient. They tend to be vitamin D deficient. They tend not to get enough fiber in their diet. They tend to be low in choline and calcium. But these are all things that plenty of kids have. So nobody's found any major nutrient deficiency that kids with autism have that other kids don't have, and nothing to explain their autism symptoms. I think in some kids, you're going to end up looking for liver disease or pancreatic disease. You may do tests for celiac disease or gluten-sensitive enteropathy if they have symptoms to support that, and look for food allergies if they have symptoms to support that. And you can do that through both blood and skin testing for allergies. And then the endoscopies, which are basically the upper endoscopy or the esophago-gastroduodenoscopy and the colonoscopy, where you're looking grossly, and then they do biopsies looking at tissue and looking for evidence of inflammation and disease. They can also look for causes of malabsorption on an upper endoscopy. It would pick up if there's inflammatory bowel disease or eosinophilic esophagitis. Anyway, so I wanted to tell you in the last few minutes about a consensus report that if you're at all interested in this topic, you have to get this. It came out in 2010. It was a supplement in pediatrics. And actually, the entire supplement was devoted to GI and nutrition in autism spectrum disorders. But the first two articles are specifically related to GI. And I'm going to go through. They had 23 statements that they made. And I condensed them a little bit, but basically they're all here. So individuals with ASD deserve the same thoroughness and standard of care in the diagnostic workup and treatment of gastrointestinal concerns as should occur for patients without ASD. So basically we need to pay attention. When people say they have a problem, we should treat them the same way we would treat anyone else. The problem is communication a lot of times and figuring out how to elicit a good history, because without being able to get a history, I don't know what tests to do. And so I think that's sometimes where we get frustrated, both on the physician side and on the parent side, is you're trying to figure something out with a child who can't communicate very well. Number two, GI conditions are commonly reported in individuals with ASD. So since this statement was made, they came out with that meta-analysis which confirms pretty much that it's 4 times that of other kids. And it's the same biggies. Number 3, prevalence is incompletely understood. I think it's better understood than when they made this statement, but we're still not exactly sure. Number 4, the existence of a GI disturbance specific to persons with ASDs has not been established. So nobody has determined that there's some GI problem that kids with ASD have that other kids don't have. It tends to be the same problems. There's no mysterious thing that we think is out there. Evidence for abnormal GI permeability is limited, although it's still being explored, but it's probably not the cause of most kids with ASD, either their GI symptoms or their autism symptoms. Individuals with ASDs and GI symptoms are at risk for problem behaviors. The idea that if you have abdominal pain, that can lead to other problems like self-injurious behavior. So I'm going to give you some more in a second about that. Education of caregivers and healthcare providers is necessary, meaning we need all to be sensitive to the problems that kids with ASD have. Pediatricians should be alert to potential nutritional problems because of selective diets or because of GI problems. Primary care nutritional assessment should include weight for height, weight for age, height for age, and note any marked changes in growth rate. Sorry, we're talking about looking at growth parameters to determine is there a nutritional problem. Number 11, there may be a subgroup of individuals with ASD who respond to dietary intervention. So there have been a whole bunch of anecdotal reports. Most of the good studies actually don't show any improvement with any dietary intervention, but there may be subgroups. Like if you identify the kids who have true gluten sensitivity, they probably will respond to a gluten-free diet. Number 12, available research does not support the use of a casein-free, gluten-free diet or combined gluten-free, casein-free diet as primary treatment. Don't treat ASD with that diet, they're saying. If they have GI problems and you think it's related, their GI problems are related to, say, milk allergy or gluten sensitivity, then it makes sense to put them on those diets. But that it's not going to cure their ASD symptoms, and it doesn't make sense to do that. Now, there's a lot of people who disagree with that. I'm not going to get into the argument too much, but I pretty much agree with that statement. For patients with ASD, a detailed history should be obtained. Now that's the hard part, getting the history. And we need to consider allergy, because allergy is very common in children in general. And that allergies may contribute to the behavioral problem. So if you see an exacerbation in behavioral problems, maybe it's due to a food intolerance. Number 14, we need standardized definitions. Number 15, a detail, I skipped that, okay. 16, involvement of specialists such as allergists, GI, dietitians, feeding therapists may be helpful. 17, immunologic aberrations in individuals with ASD have been reported, but a direct cause and effect relationship has not been proven. So still being investigated. So there's no treatment we can base on this right now, no diagnostic evaluation in a clinical setting that we can base on this. The role of immune responses in the pathogenesis of GI disorders and ASD warrants additional investigation. Is there a role of the gut microbiome? Is there a role of inflammation in the gut? I sort of said that one as well. And then these all have to do with research agenda and saying we need more research, we need better methods, we need to characterize the type of ASD we're looking at and the types of patients we're looking at. We need to better characterize the GI symptoms, and we need more clinical trials and looking at genetics. So I already sort of mentioned these concepts already, that you can have functional abdominal pain. What are the behavioral manifestations of pain? So you can have vocal behaviors, you can have motor behaviors, you can have changes in overall state. So these are the vocal behaviors. So clearing of the throat, swallowing repeatedly, tics, screaming, sobbing, sighing, whining, moaning, groaning. They describe delayed echolalia, saying stomach hurt, but repeating what somebody said, but doing it maybe a minute or two after it's been brought up, or direct verbalizations like tummy hurts, or pointing and saying hurt. Motor behaviors, so grimacing, gritting of the teeth, wincing, applying pressure to the abdomen, holding your belly like this, or tapping your finger like this on your throat, jaw thrusting or arching of the back could be a sign of reflux, or the idea that anything that's abnormal for that child might be a sign that there's something going on that they can't verbalize in some way. Changes in sleep habits. So reflux definitely can make somebody more uncomfortable while they're sleeping. Abdominal pain can too. Increased irritability. There may be more non-compliance or increased oppositional behavior when somebody's having abdominal pain or GI symptoms. And I wouldn't say these things are specific to GI. I would say they could be due to any cause of pain, but GI-related pain is probably pretty common, and it's not something you can easily see. Whereas if somebody, bumps their knee and they have bleeding from their knee, it's obvious. If they have internal abdominal pain, it's not as visible. They happen to mention in the article, that if you suspect malabsorption, sometimes the best way to figure it out is to do an endoscopy and measurement of disaccharidases, which are the enzymes that digest sugar. And then just briefly, some of the theories I mentioned already. So this guy in '91 theorized that gluten and casein were similar to opioids and that sort of affected your brain activity. Then you guys have all heard of Andrew Wakefield and the whole measles, mumps. Well, he also had a theory about GI symptoms and autism, and that he reported in '98 that many of the kids with developmental regression had an ileocolitis, or what he called an autistic enterocolitis. And so the idea of gut inflammation contributing to the autism, but he's been pretty much discredited since then. But I think there's some people who still believe in that, even though they don't necessarily believe in his report of it. And then I'm going to not bother with this. If we had time, I was going to talk to you about sort of more feeding disorders and food selectivity, but why don't we see if there's questions or